The House Health Policy will come to order. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett.
Here.
Carter. Hadsma. Neely.
Here.
Glanville.
Here.
Kafia.
Here.
Conlon.
Here.
Farhat.
Here.
Fitzgerald.
Here.
Miller.
Here.
Rangan.
Here.
Vanderwall.
Present.
Filler. Mueller. Van Workum.
Here.
Roth.
Here.
Schmaltz.
Here.
Thompson.
Present.
Madam Chair, you have 17 members present. You do have a quorum.
Thank you. Could the record reflect that Representative Hadsma and Mueller are also here? Yeah. Representative Carter moves to approve the minutes from our meeting on November 2nd. Seeing no objection, minutes are approved. Today, we have a very full committee, and we will hear testimony on House Bills 4550, 4551, and 4552, known together as the Safe Patient Care Act, which would establish nurse staffing ratios in hospital settings. We have an abundance of individuals wishing to testify, and it is likely we will not have time for everyone who has submitted a card to speak. I apologize. If we do not have time for your testimony today, I would welcome you to submit written testimony to the committee. In order to hear from a variety of perspectives on the legislation, I am asking committee members to withhold their questions until the end, where I will reserve time for members to have their questions answered. To give members a preview of the order of testimony, we will begin with the bill sponsors, then nurses with the Michigan Nurses Association, and an individual with a personal tragedy resulting from a shortage of nursing staff. Opposed to the bills, we will hear from the American Nurses Association of Michigan, followed by Michigan Health and Hospital Association and others representing hospitals. We will then proceed with questions for those opposed to the bills before returning to questions for those who testified in support. First, we will hear testimony on the bill package from the sponsors of these bills. Representative Young, Kafia, and Reingans, thank you for joining us, and begin when you are ready.
Thank you, Madam Chair, and to the committee. We appreciate the opportunity to come before you on today. We're here to speak to the Safe Patient Care Act bill package. My bill, House Bill 4550. 4550, which has nearly 4 dozen co-sponsors, including many of our colleagues here on the Health Policy Committee, deals with the urgent issue of nurse staffing in our hospitals. This is a bipartisan bill package. We are facing a crisis in nursing and in healthcare more broadly. Unsafe working conditions in our hospitals have led to a deterioration in care for Michigan patients. Nurses who are being worked to exhaustion are voting with their feet and leaving the bedside in droves, creating a downward spiral with no end in sight. Virtually all of us will need care at a hospital sometime between birth and death. I recently had an opportunity to spend time in a hospital with my son who had an accident. He had a bicycle accident, and I overheard a nurse saying, "Oh, I almost made it home. One more patient." And that happened to be my son after they thought they were done. What some people might not realize is that there is no law about how many patients a nurse can be assigned during a shift. This bill sets safe limits on those patient assignments by unit. Too often, nurses have too many patients to take care of, resulting in poor outcomes for patients and, quite honestly, for our nurses. These conditions have caused an unsustainable exodus of nurses from the bedside. I have heard too many stories from nurses across our state that speak to a problem that goes well beyond just burnout. It is actually moral injury. That's right, moral injury. When it comes to having to make the heartbreaking decisions about who to save and who they don't, because they just can't do it all. Nurses don't deserve to be put in unsafe working conditions where they simply can't provide the care that patients deserve. So this bill sets limits on the number of patients that can be assigned to a nurse. For example, 4 patients to 1 nurse on a medical surgical floor, which is a typical inpatient floor. Research shows that once a nurse goes beyond 4 patients, poor outcomes are more frequent. We frequently hear of nurses having to take care of 8, 10, even 12 patients on a medical surgical floor. That is extremely dangerous. And we'll hear more about this from nurses who actually take care of patients day in and day out. Nurses deserve better. Michigan patients deserve better. And that's why we must shine a light on the fact that the nurse staffing crisis is a public health emergency in our state and is something that we can do something about. I think we all share a belief that all patients, no matter where they live, deserve to be safe in a hospital and receive quality care. One more. I think we all share a belief that we want to do everything we can to keep our nurses working at the bedside. This safe staffing legislation is an important part of the solution that we have control over and can do something about. That is what bedside nurses are telling us that they need in order to provide quality care to every patient and keep working at the bedside. And I believe it's important to listen to them. We know that all hospitals aren't created equal. Just like with anything else, there are good actors and there are actors that could use some help. And I believe this legislation will help our bedside nurses and will help our hospitals in general. And so I want to thank you again, Madam Chair, for holding this very important hearing on today, and to the committee. Thank you as well.
Thank you for your testimony, Rep. Kofia.
Thank you, Madam Chair. Thank you, Chair Rogers and committee members. I'm here to testify as part of the Safe Patient Care Act bill package on my bill in the package, which is House Bill 4551, and it specifically addresses mandatory overtime in Michigan for registered nurses. Nurses are the heart of healthcare. And I've shared with some of you in the past, I have had extensive experience in the last few years with our healthcare system, and specifically with nurses due to a severe illness during COVID. During 2020, I had major brain tumor, craniotomy, multiple days in the hospital, and it was the nurses at my bedside more than anyone else that I felt like helped carry me through that, frankly, terrifying moment. So I feel especially compelled and committed to helping, listening to the nurses and helping create the best working conditions possible for all nurses wherever they practice in Michigan. One of the problems right now is that there is no limit on the number of hours a nurse in Michigan can be compelled to stay on the floor working. Typically in a hospital, nurses work 12-hour shifts, which is long as it is. However, if they are ordered to stay, that shift might end up being 14, 16, or even 18 hours, and oftentimes they then have to come back the next day. While some union contracts have language regarding mandatory overtime, it is important to remember that most nurses in Michigan are not in a union, and they have no protection against this at all. A nurse who refuses to work overtime can face retaliation currently legally in Michigan and threats of losing their license, even termination from employment for refusing mandatory overtime because they feel simply too exhausted to continue and feel that they are putting their patients in jeopardy. Research cites the fact that workers are more likely to make critical errors when they are exhausted or sleep deprived. We already have regulations for workers who have other people's lives in their hands, such as truck drivers and airline pilots, where there's a cap on how much overtime they can be required to do. Hospital nurses, too, are critical to public safety, and we should protect them from having to work excessive hours. My bill specifically limits RNs' working hours to what they're scheduled for and gives nurses at least 8 consecutive hours off after a 12-hour shift. This keeps our nurses from having to work while exhausted and potentially put their patients' lives at risk. It is dangerous to have a nurse who is in their 18th hour doing the complex work that nurse is doing, working with a brain tumor recovery situation like my own, for example, or putting an IV in a newborn, calculating dosages in the middle of the night for ourselves or our loved ones. It is also very disruptive to nurses' lives to have to stay unexpectedly, especially for those who have children waiting at home. And in my area, which is rural, we're talking sometimes an hour to 90-minute drive home to those children and then turn right around and go back to work. Because of this and much more, mandatory overtime can be another factor that drives nurses out of the profession, and we should join the other states that have regulations on this. And I want to share some statistics here. Currently, 18 states have enacted laws or regulations applicable to nurses that either prohibit or limit mandatory overtime for nurses. These are red and blue states: Texas, West Virginia, Oregon, Massachusetts, and Washington. These policies are also currently in place in many Midwestern states like Missouri, Illinois, and Minnesota. And many of them have rural areas like mine in northern Michigan. This bill recognizes, too, that unexpected things can happen, and there are exceptions carved out for declared emergencies, and we are also working on other bill language to make sure hospitals aren't penalized in the case, for example, of a mass casualty incident. We are listening to hospitals when they say they need assistance with training and attracting and retaining staff. They have asked us in the legislature, and many of us here voted for increased penalties for assaulting nurses, and we are moving those bills. They have asked us to use state dollars to help them attract and retain nurses into the workforce, and one of our first votes in January was $75 million to the hospital for attracting and retaining talent. We also listened to them when they asked us to help fill the talent pipeline by using taxpayer money to lower the age of Michigan Reconnect to move more nurses into the pipeline. The problem is that there's a hole in the bottom of the ship. There is a study that U of M did recently that showed that nearly 40% of Michigan's nurses are planning to leave their job within the next year, according to this study in 2023. And perhaps most concerning was the finding that the youngest nurses are now the most likely to leave the profession. Nearly 60% of those polled under the age of 25, and more than 50% of those 25 to 34 years old say they plan to leave the job within the next year. So there's a hole in the bottom of the ship, even as we are putting taxpayer dollars to try to fill the talent pipeline. I believe if we want to attract and retain talent, it starts with listening to what the workers are telling us. Mandatory overtime rules, as well as ratios, are what they are telling us they need to have safe working conditions. Thank you for considering my testimony today.
Thank you, Representative Rankins.
Thank you, Madam Chair and fellow committee members. As a public health professional, I believe strongly in the value of data and the importance of transparency when it comes to data. Right now, we have no public data on the actual nurse-to-patient ratios in Michigan hospitals. My bill would change that. Why do nurse-to-patient ratios matter? Decades of peer-reviewed research, as well as nurses' lived experience, show the connection between the amount of time an RN has to spend with a patient is connected to the outcomes of that patient. We also know that when bedside nurses have unreasonable workloads, that's a significant factor in driving them out of the profession. And we know this because they tell us this. That's why I'm proud to sponsor the third bill in the Safe Patient Care Act, HB 4552. It's a very simple bill, just one paragraph. It requires hospitals to disclose the actual RN to patient ratios that were used in prior shifts. I believe this has value for two reasons. First, we, the public, as the patients and also the funders of healthcare, we deserve to know what kind of care we're going to receive at a hospital. For example, if I'm having open heart surgery and I know that I'll need to be in an ICU for some amount of time, I'd like to know whether my nurse will have one patient or 4 patients. Because, quite frankly, research shows us that this number, the nurse-to-patient ratio, will affect my chances of survival. And unfortunately, there are hospitals in Michigan where nurses have to juggle 3 or 4 patients in intensive care, when research studies show us that the best practice is to have 1-to-1 bedside nurse to a patient ratio in that situation. Secondly, and lastly, I believe that when information like this is publicly available, it encourages the best results, rewards the good actors, and can create a virtuous cycle that deeply respects bedside nurses. Residents deserve the best possible care, no matter where they live in Michigan. Thank you, Madam Chair, for holding this hearing, for allowing me and us to testify on the Safe Patient Care Act.
Thank you so much. To testify in support of the bills, we have President of the Michigan Nurses Association, Jamie Brown, and registered nurses Carolyn Clemens, Rachel Hunt, and Nikia Parker. And we are under an extreme time constraint as we have to return to session afterwards. I'm giving 15 minutes total for the pro testimony and 15 minutes total for the opposition. I'm sorry for the time constraints. Begin when you are ready.
Thank you, Chair Rogers, for holding this hearing and allowing me to testify in support of the Safe Patient Care Act. And thank you, committee members, for your time today. I also want to thank the sponsors of this important package for all their support in bringing it forward. My name is Jamie Brown. I'm a critical care registered nurse at a West Michigan hospital with over 20 years of experience and president of the Michigan Nurses Association. The issues we're talking about today are not just important to our members, they're also urgent to tens of thousands of other Michigan nurses, both in unions and not, as well as to countless patients and their families. 93% of Michigan RNs polled support passing the Safe Patient Care Act, and a majority of them say they would return to or stay in direct patient care if it passes. Research from Dr. Linda Aiken and other experts have shown that hospitals can save lives and save money by following safe patient nurse to patient ratios. We understand the need to look at all possible solutions to solving this crisis, but a supply-only approach will not work. According to the study this year by U of M professor Christopher Fries and others, 39% of Michigan nurses plan to leave their job in the next year. This increases to nearly 60% for younger nurses. We have a leaky bucket. No matter how many nurses we graduate or bring in, nothing will change unless we address hospital working conditions. In the meantime, there is a related patient safety crisis in our hospitals. According to a poll done this year, 42% of Michigan nurses know of a patient dying due to nurse understaffing. That's nearly double from 2016, when it was 22%. There are also other preventable adverse outcomes such as falls and hospital-acquired infections that cost the hospitals hundreds of thousands of dollars each year. There is a growing understanding that laws requiring safe patient care assignments are needed. In fact, the American Nurses Association for the first time recently expressed support for federal legislation setting nurse-to-patient ratios. We want Michigan to be a leader and a place where nurses want to work. The Safe Patient Care Act will make that a reality more than any other intervention. I'd like to conclude by sharing some words from a fellow critical care nurse named Brindy. It is not fair that people live or die because of short staffing. I have been forced into unimaginable life or death circumstances countless times because of this constant issue. I am an ICU RN for over almost 20 years and it has done nothing but to continue to get worse. Last year I coded someone in an ICU for 10 minutes all alone because there was no one to help me. I no longer can sleep because people did not have a fair chance at surviving. It breaks my heart telling family after family their loved one died, especially under my care when I know they may have had a chance of living if staffing was better. I wish everyone could have looked into the eyes of the people I watched died because of unsafe staffing. If legislators looked into the eyes of everyone I have watched died, even in just the last few years, I guarantee you they would also suffer from insomnia and PTSD. One day you could be laying in an ICU bed, and I bet you don't want to hear that your RN has 4 other intubated patients trying to die. That's not what my patients want to hear either. Thank you.
Hello, Chair Rogers and committee members. First, let me give honor to God, who is head of my life. Thank you for your time today. My name is Carolyn Clemens, and I'm a registered nurse in Grand Blanc area. I am also a leader in my local union, Teamster 332, which supports all 3 parts of this legislation. I am a member of the State Board of Nursing, although I'm not here in that capacity today. I have been a registered nurse for more than 2 decades. I currently work in the special care nursery with fragile newborns. I also have over 18 and a half years of experience in medical intensive care unit. Nursing is a tough job, and we all accept that. However, hospitals are making it even tougher than ever to do our jobs. I worked throughout the pandemic where we lost valuable family members, but nothing was more devastating than when we lost 52 people in 30 days. That was my breaking point. Upon arrival the next day, I sat in my car crying and shaking, not wanting to go to work. It was not the pandemic and death per se, although that definitely took its toll. It was more the fact that I didn't feel supported by my administration. Understaffing started before the pandemic, continued through it, and continues today. We are often scheduled short with no plan. I have been left as the only specially trained nurse to take care of 8 babies on the unit, 8 fragile newborns. These are babies that may be on ventilators, have chest tubes, have IVs. They have complex special needs to keep them alive. This is someone's child. I think of my own grandchild being that vulnerable, and it makes me sad and angry. There is serious risk to the babies, and there is unbelievable stress for me, trying to monitor and take care of all of these children. The trauma that this causes me and other nurses is hard to measure, but we feel it every day. My frustration is that administration is not planning properly for our staffing needs so that we can actually do our jobs and keep these little babies safe and get them healthy. That's why we need a law that establishes safe limits on patient assignments so that nurses aren't sitting in their cars crying, wanting to go into work, or quitting and leaving nursing altogether due to making difficult decisions about who gets care and who has to wait. So please, we need your support to support us so we can support our communities. Thank you for allowing me to share my thoughts on the Safe Patient Care Act.
Thank you, Chair Roberts and committee members. My name's Nakia Parker. I came down from Wexford County today for this hearing. I've worked as a registered nurse in the emergency department of a Northwest Michigan hospital in one capacity or another since 2005. But I also have experience working in various hospitals across the state, from rural access hospitals to large teaching hospitals, as well as experience working in California, where nurse-to-patient ratios are legislated. Over a year ago, I made the really difficult decision to walk away from the career I feel I was put on this earth to do, and that is bedside emergency room nursing. It's the thing that defines me most, aside from being a mother. At the core of what we do as nurses is advocate for our patients, all patients, to make sure that they leave us a little better than when they came to us. So when you go home after 12, 16, or more hour shift and you can't sleep because all you are thinking about is, did I miss something? Did I forget that? Did someone get hurt because of the care I provided? Or worse, because of the care I wasn't able to provide? Or God forbid, did someone die because of something I didn't or couldn't do? The moral injury eats at you. It kills you a little bit every day to the point that you become paralyzed in fear for doing your job. 10 years ago, my 17-year-old cousin Owen died in my emergency department. I was working that day, and I watched a highly trained, experienced, and robustly staffed team of my work family give him every possible chance at survival. His death was tragic, but I have peace. Peace knowing that understaffing and nursing resource rationing did not contribute to his death. This year, I lost a friend. He also died in the hospital in which I work after multiple encounters with both outpatient and inpatient facilities. I know there were times that he was cared for by nurses pulling far more weight than is safe, nurses forced to ration their care, and inexperienced nurses who lacked support because their experienced coworkers were also drowning. I will always wonder how much that contributed to his outcome. I will never have peace in his death, and it will haunt me and likely the people that cared for him for the rest of our lives. Situations like this broke me. The moral injury became too much. I made the decision to take a 50% pay cut to leave bedside nursing and become a paramedic full-time. I still work 1 day a week in the emergency department because despite the abusive environment, I just can't bring myself to completely walk away from the community I deeply care about when they are at their most vulnerable. But so many of my coworkers have left due to moral injury, and we are burning out the few new nurses that we can convince to join the fight. I am an example of how there is no shortage of available nurses. 50,000, according to Lara and the Bureau of Statistics, that are registered nurses licensed to work in the state who are not choosing to work here. If the Safe Patient Care Act is passed and we have ratios, I'm one of those nurses who would return to the bedside full time, and so many of my coworkers that have left would join me. Please stand up for the nurses that are here, the nurses that couldn't be here because they're working, and the people of this state who deserve the best possible care.
Good afternoon. My name is Rachel Hunt. I'm a registered nurse, and I became a nurse to care for people on what could be one of the most difficult days of their lives. My patients are more than just a room number to me. They are humans that deserve to be treated with dignity and respect. I've had the opportunity to also travel around Michigan and work in several hospitals throughout our state, both union and non-union. This experience has allowed me to gain insight into one thing our Michigan hospitals have in common, and that is substandard working conditions. And this has endangered the patients and our healthcare workers. And this is specifically due to unsafe nurse to patient ratios. This puts nurses in situations where we are forced to prioritize the care of our patients throughout our entire shift. Nurses should not have to choose if we are going to pass urgently needed medications or if we're going to change our patients who have been sitting in their urine and feces for hours. And I mean hours.
I'm sorry to interrupt. We do have 4 minutes left, and I know you have someone that wants to testify with a personal story.
Patients shouldn't be left with life-altering disabilities due to a stroke that could possibly have been prevented that were caught in time with life-saving medications. My Christmas shouldn't be ruined by the what-ifs of a patient that went into respiratory arrest. The real question should be, why are my fellow nurses and I constantly caring for critically ill patients in high ratios? Sometimes up to 11 patients per nurse. This isn't new. This has been going on for many years. And since no one is listening, nurses are leaving. We are losing our older nurses with wisdom and our newer nurses who are overwhelmed and overburdened. I am one of those nurses who has left. It's demoralizing to leave every single shift knowing I cannot possibly provide the care patients deserve that I am trained to give. And I would also come back if this bill passes. So.
Thank you. We're going to pause the timer a second, switch out, and then I think we have Mr. Tim Lillard with a personal story. Welcome to Health Policy, and begin when you're ready.
My name is Tim Lillard. I'm not a nurse. I don't work in healthcare. I'm a police officer. Last October, both my wife and I, her name's Ann, we got COVID. It was pretty mild and we were doing good. But I watched her health decline and she required.
I'm so sorry. Can you turn your microphone on? Just the red button.
Oh,
Thank you.
I'm sorry.
That's okay. Just continue.
Her health decline required hospitalization. Over the course of the next 3 weeks, I watched her health go up and down. She had endless IVs. Medications and went into ICU. During her time there, I spent every day with her, often for more than 12 hours at a time. I was really very familiar with her care and observed how few nurses were working. After she went through, turned to the better, and quickly declined again, we were told that she may not make it through the day. After updating my kids, I received a call from the hospital that Ann's heart stopped. But they were able to get her back. And when I got back to the ICU, they were doing CPR. And she died at 12:30. After that time, I tried to understand why she died, because I was told it was from some sort of infection. I got all of her medical records, talked to the nurses and doctors that I know to try and understand why she died. And every time I talked to somebody, said she died from sepsis. Every year, more than 270,000 people die of sepsis, and it's largely avoidable. The deaths, just if there's enough nurses. When I was in the hospital with her, I saw how understaffed it was. In fact, one day it was so bad I even said something to one of the nurses. Nurses need adequate time to catch these subtle changes because it mimics COVID and the flu. It's my belief, had there been nurses adequately staffed, the subtle changes in her health would have been caught and she'd still be alive.
Thank you, Mr. Lillard, for that difficult testimony. If you have any final sentences you wanted to wrap up with.
I do. It's my mission to support the Patient Care Act, Safe Patient Care Act, even before finding out about it. Unless you've had a loved one go through this, you simply can't understand the heartbreak we've endured. Please take action so that no other person or other family endure this loss. You can make a difference in saving lives. Thank you.
Thank you, and please accept my sincere condolences for your loss, and thank you for sharing your deeply personal testimony today.
Thank you.
Next, we will hear from Bethany Campbell-Skillen, Trinity Health Manager for Geriatrics and Advanced Care Coordination Program in Grand Rapids, testifying on behalf of the American Nurses Association of Michigan in opposition. We will have 15 minutes for this total opposition piece. Begin whenever you are ready.
Thank you, Chairwoman Rogers and esteemed committee members. I'm very grateful for the opportunity to provide testimony on this legislation, which is so personal for me, for patients and families, and for all my fellow sisters and brothers in nursing. I'm here representing ANA Michigan. We're a statewide professional nursing organization with over 3,000 members, representing the needs and interests of all nurses in our state. Our association is comprised of nurses employed in every healthcare setting, including acute care, long-term care, academic nursing faculty, nurses working in home care, public health, school-based care, retired nurses, and students enrolled in nursing education programs, including my son Sam, who's here with me today. I'm here to express our strong concerns with House Bill 4550. There is a nursing shortage in Michigan. Nurses are burned out. Patient safety is at risk, and something needs to be done. But House Bill 4550 isn't it. Mandatory codified ratios do not address the complex nature of the work that we do, including the fact that it ignores patient acuity, skill mix of the nursing staff, and the availability of resources. The bill only addresses staffing concerns within hospitals when issues relating to safe staffing span the entire continuum of care. Mandatory ratios will limit innovation, like the Trinity Health Together team model, which incorporates a virtual nurse in the hospital setting. Research is inconclusive as to improved patient outcomes and safety with mandatory nurse-to-patient ratios. And lastly, mandatory ratios disempower nurses, the very same people that this legislation says it supports. But all hope is not lost, because nurses are some of the smartest people on the planet, and we work in the most trusted profession, 22 years running. So don't disempower us with codified ratios. Empower us by involving frontline nurses in staffing, planning, and decisions. We recommend that organizations establish staffing committees with accountability for reporting transparency from the frontline staff to executive leadership. The frontline nursing voice must be prioritized and empowered within each workplace when decisions directly impacting nurses are being deliberated. We recommend joining the Nurse Licensure Compact. Currently, 41 states and 2 U.S. territories are part of the Nursing Compact. A recent survey of over 7,000 Michigan nurses shows overwhelming support for Michigan to join the Nursing Compact, agreeing that the compact would improve access to nursing care and would not weaken patient protections. Lastly, create a statewide inclusive task force on nurse staffing using nursing experts from across Michigan to create an actionable and sustainable legislative package of bills that will improve the pipeline for incoming nurses, will retrain nurses interested in returning to the bedside, will support innovative staffing models, and will help develop retention efforts and support for new nurses in their first 1 to 3 years of practice.
Thank you so much for your testimony. We do have 4 more individuals wishing to speak. We will now hear from Brian Peters, CEO of the Michigan Health and Hospital Association. Mr. Peters will be joined by Beth Charlton, BSN RN, MHA President, CEO of Covenant Healthcare, Doug DeScenzo, DNP RN, CENP Regional Chief Nursing Officer, Trinity Health Oakland Hospital, and Bonnie Krushka, DNP FNPC, ENPBC Vice President and Chief Nursing Officer of Ambulatory Care.
Thank you, Madam Chair and members of the committee. Really appreciate the opportunity to share the perspective of the Michigan Health and Hospital Association on this very important matter. I know we are on a very short clock, and so in the interest of time, let me just lift up several very quick points. Number one, whether you are here today wearing a red t-shirt or a teal t-shirt, I think we can all agree that our nurses have an incredibly important and impactful job. They have an incredibly stressful job, and they deserve our full support. There's no question about that. In fact, our Michigan hospitals throughout the state currently employ over 60,000 nurses, and for many months now, we have been desperately trying to hire some 8,400 more. We have been trying everything in our power to bring those nurses to the front because we need them. We desperately need them. As you just heard, there is not only a Michigan nursing shortage, there is a national nursing shortage. The factors that underlie that shortage are many. They are multiple. But at the end of the day, here's what I want you to understand from our perspective. Later today, we will share an open letter with all Michiganders that is signed by every single hospital and health system in the state of Michigan. The MHA represents the totality of the field. Every hospital in Michigan, large and small, urban and rural, is an active, engaged member in good standing in our association, and they all unanimously will be signing this letter that stands out in opposition to mandatory nurse staffing ratios for some of the reasons that you just heard from the prior presenter and for the reasons you're about to hear from the other presenters on the dais with me at this moment. I am not a nurse, but the woman to my right is. Beth Charlton is the president and CEO of Covenant Healthcare and is a longtime nurse herself, and I would now like her to explain exactly why the MHA and all hospitals throughout the state have such deep concern with this proposal.
Thank you, Brian, and thank you, Representative Rogers and the committee. I am, as Brian mentioned, Beth Charlton from Covenant Healthcare in Saginaw. We are a 623-bed hospital that serves a diverse community in the middle of this great state. I began my career 35 years ago almost as a bedside nurse, and I am now responsible for the management and operations of the hospital and care delivery system. With about 2 million patient touches annually, I'm proud to say that the staff at Covenant continues to recognize my nursing experience, nursing leadership experience, and my commitment to being a bedside nurse and its influence on patient care. Caring for patients in our region is our responsibility. It's my responsibility. Caring for our entire staff, including our registered nurses, is also my responsibility and my priority. Every day, every night, and at all times. Balancing the care of our patients and our nurses is my job. Thankfully, I share the work with our chief nursing officer and other nurse leaders and staff nurses in our hospital. We have about 1,200 nurses in my institution. This balance of patient care, and with that and our nurses in mind, please let me offer you a single message. Mandated nurse ratios are not a solution to our staffing challenges. Covenant, like other hospitals you hear from today, do use staffing ratios as guidelines for staffing. The numbers come from benchmarks, and they serve as a starting place only to consider actual patients and the care that they require. Decisions and assessments about nurse staffing are made frequently and adjusted throughout the day and the night. Nurses that consider the actual patients in the actual beds. These decisions also consider the availability of other team members in the patient care delivery team, LPNs, patient care techs, medical assistants, nursing assistants, respiratory therapists, phlebotomists, transporters, etc. The list goes on and on. A key resource in one area might not be replicated throughout the entire hospital or enterprise, and to assume so with a mandated ratio is unwise. In addition, anyone who works at the bedside realizes the consideration of your unit, your team, your patients, and the circumstance of your shift is necessary. For example, as an ICU nurse, you know having patients near arrest or a fresh open heart patient is very different than having step-down patients who are ready to transfer out. With mandated staffing ratios, we must staff the ICU with one nurse for every one patient, even if that patient in the ICU bed needs to transfer to another bed that isn't simply available at the time, med-surg, progressive, or step-down. That would be an unwise use of a precious nursing resource. Also, in unusual circumstances. For example, last fall, throughout our state and throughout the nation, there was a serious outbreak of what's called RSV, a serious respiratory illness among infants and children. Covenant offers pediatric care for children and babies who are seriously and critically ill. Last fall, there were not enough staffed pediatric beds at Covenant or, frankly, in the state. Enough beds able to take care of all children who were seriously ill or critically ill with RSV and other serious conditions. Children with a serious case of RSV have difficulty breathing. If they don't receive the right level of care, RSV can be deadly. And there simply were not enough nurses to take care of these children per our traditional means. At Covenant and across the state, collectively, we had to be creative to keep these kids alive. Creativity that would be impossible under mandated ratios being discussed today. We did our very best to meet the needs of children in our state. We stretched, redefined who went where, and we followed a non-traditional path and took care of the children who needed care. Mandated ratios are not a solution to our staffing challenges.
You do have 5 minutes left in total. Thank you.
Okay, I will summarize. As nurses, I just would like to simply state that this work that we do, we are not producing widgets. We take care of human beings. Caring for people often prompts unexpected needs and therefore a non-traditional path, collaboration, and innovation. Let me continue to support that in my organization and across this great state. I implore you to support talent pipeline and educational affordability strategies instead. As a nurse and a person very dedicated to quality care for over 3.5 decades, I thank you for listening.
Good afternoon, Chair Rogers and members of the committee. Thank you for the opportunity to testify today on behalf of Trinity Health Michigan. My name is Doug DeCenzo, and I'm proud to say I am a nurse. I have served as a nurse for the past 39 years in both clinical and leadership roles, and currently as the Regional Chief Nursing Officer at Trinity Health Michigan and faculty at Madonna University and University of Detroit Mercy. This is a job and a profession I love. I was drawn to nursing because I want to make a difference in people's lives. It is a challenging job that can have a nurse feel a wide range of emotions, from happiness for a patient discharged and on a path to recovery, to grief for the loss of life. I made the decision to leave the bedside and accept a role as a clinical leader because I love my colleagues and want to make sure they have the best training and environment to provide exceptional patient care. Our culture at Trinity Health not only cares about our patients, but our nurses. In my current role as Regional Chief Nursing Officer, I'm responsible for 8 hospitals and over 6,800 nurses. What keeps me awake at night is the responsibility I have to each of them and their patients. The legislation considered today concerns me and my colleagues greatly. Staffing decisions in hospitals prioritize patient and colleague safety and are made by teams of experienced nurse managers and supervisors in collaboration with other hospital leaders. These are informed decisions made in the best interest of patients, nurses, and the community. These bills would remove collaborative decisions and replace them with a one-size-fits-all mandate. In my role, I can unequivocally assure you that our hospital in Grand Haven is distinctly different from Grand Rapids, just as our hospital in Livonia is different from Ann Arbor. And the nursing teams and patients in those communities are unique as well. We oppose these bills and what they will do to hospitals, nurses, and patients. Trinity Health Michigan recently deployed a new care delivery model that includes 3-person teams comprised of a bedside registered nurse, a virtual registered nurse, and a licensed practical nurse, each empowered to work at top of license in a complementary fashion to improve outcomes. With the aid of technology utilized by our virtual nursing cadre, we've been able to provide safer and better care, even when compared to the pre-pandemic period, and attain an improved experience of care for both our nurses and our patients. This has allowed us to create a more consistent and effective staffing model that has resulted in improved nurse retention, 24/7 support for early careers nurses, and an option for tenured nurses who can no longer keep up with the physical demands of the work, but instead leverage their clinical knowledge and expertise. Unfortunately, these bills do not offer any flexibility and place innovations such as what we've established in jeopardy. Specifically, virtual nurses and licensed practical nurses have been excluded from the proposed legislation. I would like to turn it over to my colleague, Bonnie, to hear her views.
You have 1 minute left.
Thank you, Doug. My name is Bonnie Krushka. I'm an advanced practice registered nurse, certified as a family nurse practitioner and emergency nurse practitioner with more than 20 years of experience caring for patients and leading nursing teams in primary care and emergency care settings. I still practice at the bedside today. I'm a nurse educator and I've taught at every level from RN to Doctor of Nursing practice. I'm here with my colleagues from the Michigan Organization of Nurse Leaders to express our opposition to Bills 4550, 51, and 52. As the Chief Nursing Officer of Ambulatory Services for Northern Michigan's largest rural nonprofit healthcare provider that serves more than 500,000 residents in 24 counties across 11,000 square miles, including my hometown of Manistee. I'm keenly aware of the potential harmful impact of this proposed legislation on my community. To give you an idea of the scope of geography, it is basically the size of Delaware and Vermont combined. Poor access to healthcare services
If you
in
can
rural
wrap up your last
communities
sentence, you're out of time.
is well known, and this proposed legislation threatens to amplify this issue for our rural Michiganders that are already vulnerable.
Thank you. Representative Thompson has a question. So what we're going to do is have 5 minutes of questions for you all. Then we will switch out and bring the bill sponsors and a couple of nurses back for a 5-minute period of that. Representative Thompson, and then I have Conlon.
Thank you, Madam Chair. So I am a nurse. So I'm going to use my 5 minutes because I already know what you're saying. I know what each side is saying.
Representative, you do not have 5 minutes. You have one question.
You said I have 5 minutes.
No, I did not.
You said 5 minutes to talk. 5 minutes total for all of us. Okay. What I would like you here to do is not turn this into a pro one side versus the other side. I would like to see union workers and non-union nurses working together. My question is, how can we utilize LPNs to help with the nursing shortages that we're seeing in our hospitals?
I'll take that question. We're currently utilizing them, and we know what they're capable of doing. We know what their licensure protects them to do and what they're competent to administer in the way of care. And so together with RNs, they partner, they come up with a plan for the day, and they're able to administer care safely and competently.
Representative Conlon.
Thank you, Madam Chair. Thank you for your testimony today. I'm wondering, in terms of solution seeking and the fact that you did mention, communities are different. Are you willing to work with the bill sponsors in negotiating any other kind of statewide different ratios? Are you looking at ratios for operating rooms, for instance? Is there any ratio that you would consider?
I can answer that, and I appreciate the question. Really, as we've engaged on this topic with our leadership, not only the MHA Board of Trustees, but our CEOs and CNOs, the Chief Nursing Officers throughout the entire state of Michigan, really the concept of replacing the bedside local expertise and judgment, which, as Beth said, occurs multiple times throughout the day, unit to unit, shift to shift. They have eyes into the acuity level of patients, the training of the care team, the technology that may or may not be available, to replace that with a mandatory approach. is unacceptable to us regardless of what those numbers are. It's the concept of replacing that localized expertise with a one-size-fits-all mandate that we find objectionable. So the answer really is no, but we look forward to working with all parties to solve the underlying issues here, to address the nursing shortage and to create higher quality access care for our patients.
Thank you. And Representative Hadsma, is your question for this group?
Yes.
Thank you. Go ahead.
Mr. Peters and others, thank you for your testimony. It's my appreciation that last week on the 1st of November, the American Nurses Association released a statement in support of minimum nurse staffing standards nationwide. The statement reads in part, ANA supports nurse staffing ratios as a solution to solve the current crisis. The website continues that minimum nurse to patient ratios is one of many alternatives and solutions to achieve appropriate nurse staffing. The American Nurses Association supports enforceable ratios as an essential function to achieve appropriate nurse staffing. Is there discrepancy between what the American Nurses Association declared just last week and that which you're depicting in opposition to these bills today?
And I do think that would be a question to be posed to our ANA Michigan presenter. But again, we would take exception with that particular statement and that recommendation for all the reasons that we've described.
Thank you.
Thank you. If you want to all switch out, if the ANA representative could come up. Thank you so much for your testimony.
Thank you.
Were you able to hear the question, or do you need it repeated?
Yeah, I heard it.
Thank you.
so much. Thank you for the question, Representative
You're welcome, Ms.
Hadsma.
Campbell Skillens, I think, right?
Campbell Skillen, right.
Okay.
Thank you. Yeah, so ANA National does empower states to advocate for their specific and unique needs at the local level. Ratios are, as you said, one recommendation, but many of the other recommendations that we've made are also on their list of things that they would recommend from the national level as well.
Thank you so much. All right, next up we're going to have, I think Representative Young is in the room, and maybe a couple nurses want to come back up for questions. I don't know if Rep. Kofia, okay, that's fine. All right, so first up we have Representative Filler with a question.
Yeah, we've kind of heard that nurses are sitting on the sidelines, sort of waiting for a better ratio. And as soon as this becomes law, thousands of nurses will sort of flood back into practice. And I guess my issue would be if it does turn into law and the nurses don't flock back, or simply the stats are wrong, that we're going to severely hamper healthcare in the state of Michigan. I'm talking closed wards because you can't meet the ratio, inability for a hospital to treat an emergent patient. So it feels kind of to me like a gamble we're taking, and I wanted to share my concerns with you.
Sure. Thank you for that question. I'm Katie Pontifex. I'm a registered nurse. I am also the Associate Executive Director for Healthcare Practice Policy and Strategic Initiatives at the Michigan Nurses Association. And in relation to all of that, I mean, as we've stated all along, this is not this is the solution. This is part of the solution. We recognize that our healthcare system is broken and it needs to be, solutions need to come from every direction, and they really do need to be happening at the same time. This is one of those issues that addresses the staffing portion of it. We have talked to our nurses, our bedside nurses. They were part of the building of this bill, and this is part of that piece of it. When it comes to looking at what has happened around the nation, we can only really look to California. They have 20 years of research there as to how these ratios helped with their staffing. They actually did correct their nursing shortage. Bedside nurses did come back who had left. In relation to hospital closures, 8 hospitals did close after the implementation, but those, according to the California Hospital Association, those were suffering financially greatly prior to this bill passage, so it was anticipated that they were on their way to closing anyways. Research is out there. It supports all of this. It does show that
that hospitals can actually correct a lot of their savings in that regard too. Ratios have a direct correlation to outcomes with patients, and outcomes are tied to CMS reimbursements. So if we're able to give our patients the better care that they deserve and that they need, then we're going to meet those benchmarks that CMS requires for full reimbursement of care for that patient. And hospitals are actually going to see a savings. And that research is actually out there. I believe it's with Dr. Aiken and her colleagues.
Thank you. You good?
I do have to ask, though, because I did see in the bill, if a ratio is unable to be met, a fine and punishment comes to the hospital. I mean, I represent some very rural hospitals, and if they just can't find a nurse, isn't that, it's just like this rolling fine and then this rolling punishment, and that really, that scares me for these rural and smaller hospitals.
Thank you, Representative Yusuf Rapi, Legislative Director with the Michigan Nurses Association. A couple things I want to say. One, in response to your earlier question, I would, all of you have in front of you a packet of information, including polling data around nurses that were surveyed in the state, indicating that a majority of nurses would come back to the bedside if this bill were passed. So that's a really important piece of data in reference to what you were saying. So I just want to make sure that we all understand that piece of it too. I think part of this, in terms of what you were describing earlier with, the negative situations that could come about, the scare tactics kind of that are being used to describe this bill, unfortunately, care that's being provided now is already suffering. And what we're seeing with this bill is that this could be a solution to help bring nurses back to the bedside and solve some of the problems that are already in existence in our healthcare system. Last thing I'll say is we are very open to having a conversation with you and any other committee members that are interested in working on, making sure that this bill is right. We want to get it right. This is what we've put before you, what the representatives who sponsored these bills have put before you. You know the legislative process, and we are very willing to work on finding solutions to every problem that's potentially could be out there.
Thank you very much. In the interest of time, we're going to move along to Minority Vice Chair Vanderwall.
Thank you, Madam Chair, and thank all of you for being here. And of course, my passion for healthcare and making sure that we have proper staffing is extremely important. But I want to get back to California just a little bit. California's had this rule for 20 years that's in effect. A recent study still shows that there are 45,000 nurses short in California, even with the nursing ratio. When we sat down and discussed some of these things in my office, and we talked a little bit about what can we do to make sure that we fill the pipeline. And I believe that every state has an issue right now, and we have to invest in. California had 54,000, almost 55,000 applications for new nurses to come in, and only 15,000 could be accepted. So my question is, how in the world, if we see the ratio in California not working, and then with the young lady that spoke, I know that Munson's moved into a union. How are we working? How is the union working with the hospital to really work on the staffing issues? I know it's a lot there, and I know we don't have a lot of time, but I look forward to meeting with you in my office. But I'd like those questions answered if you can, please.
I think every organization, I would love to see us come together more frequently and work on them together, but I think every organization, both hospital and nursing side, is trying to address various aspects of our staffing crisis on their own, so to speak. I know that the Michigan Nurses Association is working with various charities and other schools in order to uplift our nursing students. I would love to have a discussion as to how do we encourage, incentivize our retired nurses to come back and maybe teach. That is a problem that we have. We don't have enough instructors. Meanwhile, we have also bedside nurses who are leaving because of the working conditions to go be instructors. So it's this constant problem, but we have a leaky bucket. And the pipeline is absolutely something that needs to be looked at, but we can bring in all the nurses we want to. But if we're not going to keep them, that's going to be a problem. We did get some new statistics yesterday, thanks to some investigative journalism, that Laura actually has new statistics out for the registered nurses this year. We've been using the 50,000. It's actually higher. So right now there are 175,000 registered nurses in the state of Michigan. That has grown almost 21,000 since January, which is when we had our previous statistics pulled. The Bureau of Labor Statistics is also telling us that there's only 101,000 working. In January, it was 102. So while we're adding nurses, we're also still losing them working as registered nurses. So again, this has to be a multifaceted approach. This is just one of those many, many, many pieces that need to be looked at.
Thank you. And I want to squeeze in the last question for Representative Schmaltz.
Yes, I just wanted to say that I had the privilege to go to Trinity Health in Pontiac and look at one of their virtual nursing programs. And I think it's a wonderful idea. And I think for everybody to understand, it's not just a virtual nurse. They work in conjunction with nurses on the floor. And I think this is a great way that we can possibly bring back retirees and nurses who can't walk the floor anymore to come back to nursing and help the nurses that are on the floor deal with all the patients. So I just want to say I think it's a great program, and I'm glad that they're doing this, and I look for the expansion of that.
Thank you so much. I really appreciate everyone's testimony. In wrapping up, I just have a yes or no question for the bill sponsor, Representative Young. I know there's a lot of complexities and dynamics in hospitals, one of which is called a Code Black mass casualty incident. There are sometimes circumstances beyond any of our control. We all are having shootings in our communities, for example. Is there some flexibility or wiggle room that you as the bill sponsor would be open to on that kind of thing that's unfortunately becoming more and more of it's not a rare occurrence?
Absolutely, Madam Chair. And that is something that my colleagues here, we've spoken about. This is what I call getting the legislation out of the shadows. We continue to talk about it in silos, but until we all get together in one room, do we really know what folks are thinking about the legislation? And so we've heard very interesting testimony on today. One thing that I would like to leave with the committee is this is a beginning point. We've done a lot of work, and we believe there are areas where we can come to consensus. And what you just mentioned, Madam Chair, is one of those areas where we have some flexibility and we're willing to talk about. But until we bring it out the shadows, people didn't believe we were serious about this. People didn't believe that nurses need to have their voices heard. And I'm so grateful for your leadership and allowing us this opportunity to allow the nurses to have their voices heard. So thank you so much for that.
Thank you, everyone, for your respect and your time today. I really appreciate everyone's civility on a difficult topic. If you are unable to testify, please submit written testimony to the committee. I also want to thank all the members of the House Health Policy Committee for their work on what has been a productive and sometimes emotional and intense committee today. There being no further business before the committee will stand adjourned.